All right. Well, good morning, everybody. I'm Vinny Taneja. I'm the Director of Public Health for Tarrant County, and I'm the proud moderator of these sessions about Ask the Doctors. And we have this Empowering Seniors event sponsored by our Commissioner Gary Fickus's office. 12th year running. Even the pandemic could not stop us. So we're here virtually live, broadcasting this event. And we have some great experts with us today. We're going to have two sessions. One's at 10:30, another one's at 11:30. And we have a variety of medical specialists to answer your questions. And in the 10:30 session, we have Dr. Imran Khwaja. He's a psychiatrist and sleep medicine specialist. And we have Amanda Hudson. She's a nurse practitioner. And then we have Dr. Jay Yapuri. He's a gastroenterologist, and he's a advanced specialist in therapeutic endoscopy. So that's the folks at the 10:30 session. And at 11:30, if you're interested, we have Dr. Bassem Gabash. He's a chief of oncology services at JPS. And we have Dr. Rebecca Sharp, internal medicine, and Dr. Leska Hadley, geriatric specialist in senior health. So we got a full panel today, two sessions, 10:30 and 11:30. We're going to be recording these, and they're going to be put up online after the sessions are done. So all the questions will be there. And we want to thank you all for, first of all, joining us as panelists, and all the attendees that are going to be either listening in or joining in via Zoom. We welcome you all. And we also want to thank you all for submitting your questions ahead of time. Some of the things that we had to do differently to prepare for a virtual event. So these questions are already submitted, and quite a bit of interesting topics. So with that, I'll just give it a pause and maybe see if one of our or any of our panelists want to say hi and welcome folks, and then we'll get on with the questions.
Hi, my name is Imran Khwaja. I just wanted to introduce myself. I'm a psychiatrist and a sleep medicine physician. So my practice is in Grapevine, Texas, and I primarily see adults and teenagers, and I practice both psychiatry and sleep medicine, and I'm happy to be here.
Welcome.
Thank you, Dr. Taneja, and to the Empowering Seniors Organization and organizers for inviting me again. I believe this is my second or third year participating in the event. It's clearly we're in a different mode and way of doing this than in the past, but as with many things in society, we're overcoming and finding new ways to deal and move forward. As Dr. Taneja said, I'm a gastroenterologist. I'm in Bedford, just off Central and 183. Thank you again for the opportunity.
Good morning, everyone. My name is Amanda Hudson. I'm a nurse practitioner at John Peter Smith Hospital. I work in the otolaryngology, which is the care of the ear, nose, and throat. And in particular, for the past 8 years, I've subspecialized in neuro-otology. So that's the temporal bone, the connection of the ear with the balance, face, hearing capacity to the brain. And I appreciate being here as well. Thank you for the invitation.
Well, welcome, everybody. And so let me start off with some of the questions. And, some of those are pre-submitted, and I try to kind of read and sort them to see what topic may fit. But sometimes I just throw it out in the open, see who has any answers. But let me first start off with Dr. Khwaja, because a lot of folks may or may not understand what's the difference between a psychiatrist and a psychologist. Could you explain that and how the professions are linked but different?
Sure. So psychiatrists and psychologists, they're often confused. However, psychiatrists are physicians. So psychiatrists are mostly MDs or DOs who are physicians who go to med school, and after that they finish their residency training in psychiatry, so which is a 4-year residency training. Psychologists, however, are PhDs or PsyD who are not physicians by training. So they didn't go to med school, but they have training in psychological diseases, how to manage, how to do therapy. Now, psychiatrists can also do therapy because they are trained in psychotherapy during their residency, but in the majority of the states, psychiatrists are the one who can prescribe medications because they are physicians, they are MDs or DOs, and they are trained in prescribing medications, and they are physicians. Whereas psychologists are not, they cannot prescribe medications with the exception of 1 or 2 states where they can do it with specialized training and in conjunction with psychiatrists. So that is the main difference. The psychologists do psychotherapy and some psychological tests, whereas psychiatrists are physicians. They can prescribe medications and do psychotherapy as well.
So in what type of situations one would seek care from a psychiatrist versus going to a psychologist? How does a general person know who to approach?
Sure. Now, as I said, psychiatrists can do psychotherapy. However, as the field has evolved, especially with insurances, most psychiatrists are doing psychopharmacological management, which means that they are prescribing medications. And sometimes they do some psychotherapy as well, but mostly if somebody needs to see somebody for psychotherapy, meaning they want to talk about things, they want to get some therapy, for example, cognitive behavioral therapy, and they're not interested in medications, then they may go to psychologists, where psychologists could interview the patient. They would really get to know the patient and provide different forms of psychotherapy. But if they feel that the psychotherapy is not working, then they refer the patients to us. So I work with a number of psychologists in the community. For example, a lot of times patients come to me and they want to be on medications, but medications is part of the treatment, and sometimes they need individual psychotherapy or group psychotherapy. So I refer them to my colleagues in psychology.
So since most of our audience for this event tends to be seniors,
sure,
what kind of mental health conditions do you deal with in the senior population? One of the concerns that we typically have is isolation among seniors.
Mm-hmm.
And now with the COVID-related stay-at-home and all these other issues that we're dealing with, obviously there's going to be more challenges and mental health pressures added on our community, especially on the seniors. So what are you seeing in your practice, and how do you deal with all of these things in your role?
Okay. Now, as Dr. Yapuri mentioned, we are in a pandemic and things are done differently. But in general, patients who are above 65 years of age, I mean, they have a lot of issues with feeling down and depressed. So they deal with depressive disorders. A lot of times they also have anxiety. So if you're talking about geriatric patients, they may be dealing with loss as such. I mean, loss of their functioning, having a lot of medical issues, sometimes loss of partners and social isolation. And this has not gotten better with the pandemic. So this has gotten really worse. So in my practice, when I see any patient like that, I encourage them, first of all, if they need aggressive medication management for their depressive disorder or for their anxiety disorders, I help them with that. We want to make sure that they are not getting too many medications, because at this age, people can have problems and side effects very easily. But I encourage them to have some social connection, to kind of learn the technology, to be able to connect with people on Zoom, FaceTime, or those devices where they can connect with people. One of the motto which I use in patients who are, say, have lost a spouse, or somebody who's feeling that they are 70 years of age or 75 years of age and that's it, and they don't have anything to look forward, I encourage them to change their life mottos by saying that the rest of my life is the best of my life. So I want to encourage them, because sometimes somebody is 65, they may live another 30 years, 35 years. So they got to have to plan. So one of the things which I encourage them to plan about their years, their weeks, the future. A lot of times patients or people who are like in their late 60s, 70s, if they have lost their spouse, they don't want to go back and date. But I encourage them to do that, because if they end up living another 30 years, they don't want to be living a lonely life. So that's my approach. But we do see a lot of depression, a lot of anxiety, loneliness, especially not having much of structure in their life. Like if they are living by themselves, I mean, their routines are very monotonous. They don't have anything to look forward to. So that's one of the things which most of these patients struggle with.
Yeah, that's a real challenge. So thanks for covering that topic, and I'll circle back with you with other questions. But let me ask some of these pre-submitted questions to some of our other panelists. And like I said, some of these are so general that anybody can answer. But maybe we can start with Dr. Yapuri. A very simple question: are vitamins like B complex really beneficial, or is it a waste of money? And just a reminder, you're on mute. So please unmute.
Thank you, Dr. Taneja. Yeah, that's a great question. And we're often asked in the office, not just about vitamin supplementation, but other supplements, whether they're useful or not. Um, so I would say as a whole, supplementation of like a vitamin B complex or by mouth or by pill form, the effects are kind of all over the map, and it depends what the patient's particular issue or situation is. There are some digestive issues and conditions where oral supplementation of vitamin B is not effective, and these patients require a different way or method involving an injection to supplement their vitamin B. But it's important to realize that that supplementation is in the context of patients who are either having clinical issues related to low vitamin B levels or documented laboratory evaluation that shows low vitamin B levels. But for the general population, taking a vitamin B supplement, if their dietary vitamin B levels are adequate, their blood levels are normal, we really don't know the answer to whether there's particular benefit to that or not. I suspect the answer is no. I suggest that the answer is no. Again, there are certain medical conditions that require B supplementation. Generally, oral forms of that supplementation by mouth are not adequate enough.
Okay. So I know that we have Dr. Khwaja as a sleep medicine specialist. So I think I might be getting a question that might fall in his arena, but it's kind of general. So, I'm sure there's other things involved in this situation, but so somebody has a question that their hand or arm keeps falling asleep, even if they keep shaking it off, and they can't hold anything in their hand like a phone. Their hand starts tingling or falling asleep. And then even during their sleep, it wakes them up from sleep every night. I know it's very general, but either one of you, and I don't know if Dr. Khwaja has experienced any of this or anybody else on the panel.
I have some experience. It sounds like it might need to look into the cervical neck. A nerve impingement there can cause upper extremity changes, including weakness and the paresthesias that you've been describing, where you can't quite feel it. Evaluation could happen, even starting with just primary care, talking to them about it.
Excellent. And I agree. I mean, it could be a neck nerve impingement or anything related to the cervical spine. That makes perfect sense. So while we're talking to you, Amanda, I mean, this is, again, a very general question. What advice would you give to stay well during this flu season, especially with COVID-19 being around?
It's what I teach my 5-year-old. Wash them all the time. Hand sanitizer use is, I think, a little overboard sometimes, but anytime you're going to eat, drink, touch your face, be aware of where you're putting your hands, and then wash following. The adequate diet, sleep, and activity is always great to maintain the equilibrium of health that we all try to achieve. So of course, just the things we're taught when we're young: wash them, wash them, wash them.
Yeah, and I know that a public health department gets this question every day. So let me kind of add in on that, because we get this every single day. Given that our audience is primarily seniors, seniors are at a higher risk of serious outcomes from COVID-19. If you look at what's happened in our community, most of the deaths have occurred in the senior population after they contracted COVID-19. So the risk level is high. That doesn't mean we, get scared and don't do anything or don't live our life. We just live it a little bit differently in a more careful fashion. So for seniors in particular, avoid large gatherings. Now I say that, and we started off the conversation, isolation is a problem, right? So now would be the time to get tech savvy, folks, and learn how to use Facebook and FaceTime your grandkids and leverage that technology to not miss your friends and family. And then if you're going to be going out and about, make sure you're wearing a mask and try to stay 6 feet away, which is very hard sometimes especially when you're with friends and family, but try to do that as much as you can. If there are simple things, if you're living alone, grocery pickup might be a better way, instead of going inside the store to spend an hour or two picking out groceries and other items. Get somebody to help you to make an order and then just drive up and they'll load it in your car where you don't have to get out or go visit with anybody at a checkout counter, and then you can bring it back home. So there are ways to do it, and I know it's awkward and new and different, but that's a safer way for our seniors to continue to enjoy life and still be mobile, still go visit with folks, and not be at a higher risk of getting COVID-19. Again, like Amanda said, washing your hands throughout the day is a good prevention strategy, especially when you add masks when you're visiting outside of your home. And then, you know, especially for seniors, if you come back home and you've been in a crowded setting like a store, come change your clothes, put the clothes in wash, and if the time allows, maybe go take a shower. You know, you don't want to have anything from the outside carry inside the house and later give you some risk. It sounds a little extra overly cautious, but we're just trying to make sure people stay healthy. So that's the advice. And a related question, and any of y'all can help answer, do you need to allow time between getting a flu shot and a shingles vaccine or a pneumonia vaccine? Is there any particular reason why there should be separation? Can 2 or 3 of them be done at the same time? Or are there gaps that are needed?
My understanding is that the flu shot and the pneumonia shot can be given at the same time. My understanding is that the shingles vaccine is live attenuated, and so therefore a gap from that with the other 2 would be appropriate.
Absolutely. So what is the best treatment for peripheral neuropathy? Anybody on your, maybe Amanda, I don't know if you have had any experience, but either one of y'all.
So peripheral neuropathies, they're tricky. It's a nerve that's been damaged. So if you think about your nerves, it's not something that we can really rebuild or regenerate with medication. So the idea is you want to, there are medications available for the discomfort that you may experience with peripheral neuropathies, but nothing that is going to be along the lines of a cure. Nerves, of course, can be damaged from so many different things. Diabetes is one of the big culprits. So managing blood sugars preventatively is pretty much the primary way there. As you had mentioned prior about supplements, B12, alpha lipoic acid, those have been found to be great if you're deficient in them to really help out with those neuropathies. But if you're not deficient in them, they may not cause any kind of a benefit. So it's more about keeping blood sugars controlled preventatively and then managing afterwards the symptoms.
So another question is related to sleep studies, and there's been a lot of advancements. People can actually now do these at home. And the question is, are the at-home sleep studies as reliable and detailed as those in a sleep clinic overnight? Also, second part of that question is, how much of a hassle is it to deal with a CPAP machine? And what are the concerns over cleaning of that machine and infections if you don't get to clean it regularly?
Okay. No, so can you please repeat the second part of the question?
So the second part was if it's a lot of hassle to deal with a CPAP machine every night and the concern related to keeping it clean, are you lending yourself to more infections if you don't get on a regular cleaning schedule?
Sure, and that's a very legitimate question. But let me explain to you about the sleep studies. Now, back about 10 years ago, home sleep apnea testing was approved by the Medicare, and now we are doing a lot of home sleep apnea testing as well. Now, there is a basic difference between the 2 types of sleep studies. Now, home sleep testing, now actually we just call them home sleep apnea testing, which means that they're only looking for obstructive sleep apnea. Whereas the in-lab study can be done for patients who may have other sleep-related problems in addition to sleep apnea. So the in-lab sleep studies are more comprehensive, which can look at sleep apnea, which can look at some central sleep apnea. We can do some testing for narcolepsy, for periodic limb movements, and other parasomnias, like people when they have parasomnias, when they act out their dreams and things of that nature. So we need formal sleep study, which is called PSG, polysomnogram, for more complicated patients. The home sleep apnea testing is pretty accurate, but I would say it's approximately 80% accurate for sleep apnea. Meaning, if a person wants, if has he or she has any other problems other than sleep apnea, we should do a formal sleep study. If a person has complicated medical history like asthma, COPD, heart failure, they are not good candidates for home sleep apnea. Home sleep apnea testing is only reserved for patients who are very likely to have obstructive sleep apnea. So there's a limited role, but we do a lot of home sleep apnea testing because if patients are generally healthy and we're only concerned about sleep apnea, we could do home sleep apnea testing. However, if a home sleep apnea testing does not show a person has sleep apnea, the guidelines suggest that then we have to recommend a formal in-lab study. So in-lab study is for more complicated patients, for patients who may have other sleep problems, disorders other than sleep apnea or central apnea. So in-lab studies are meant for those patients. However, the home sleep apnea testing is for patients who have simple, straightforward sleep apnea. So that's the main difference between the two sleep studies. Most insurances encourage us to do home sleep apnea testing if we are looking for sleep apnea. If you're looking for something else, then of course we can do a formal study. To the second part of the question, yes, sometimes using CPAP can be quite cumbersome. If you look at studies, in most studies, compliance or the adherence to CPAP is about maximum 50 to 60%, because it is not natural to put a mask and wear it and get used to it. However, there are techniques which people can use where they can get used to it. They need some coaching, they need certain tools, the exercises which could help. Now, for example, some of the treatment modalities are very less frequently used in sleep apnea. For example, a dental appliance, which is a dental mouth guard, which can be used to treat sleep apnea. So if a patient is having trouble with using a CPAP and they have mild to moderate obstructive sleep apnea, we could refer them to a dentist. Granted, they have good teeth, and the dental appliance can actually help pull the lower jaw forward when a person is sleeping and pulls the tongue forward, opens up the space in the back. So that is one of the treatments which is usually overlooked, but it's a very valid, very effective treatment. So I encourage my patients who are having trouble with using the CPAP to look into that. Now, as far as the question about having and cleaning the machine, I think it's very important that we, especially nowadays, that we clean the CPAP mask, the hose, and the machine on a daily basis. There are usually guidelines, there are instructions given when a patient gets a new CPAP machine, how often to clean it, usually every day with mild soap water. There are some equipments which are available where you can put your CPAP mask into a small box and it kind of ionizes it and it cleans it automatically. However, those devices are not covered by insurance. People can buy it online and they may be effective. But as far as the issue with infection, yes, I would say it is, especially nowadays with COVID, it becomes even more of an important thing because CPAP machine needs proper maintenance. They need to be having their filters changed on a regular basis. They need to have the mask clean, the hose clean on a regular basis. But unfortunately, for severe sleep apnea, there are limited options. The dental appliance does not work for severe sleep apnea. So that's the only option we have.
So I have a follow-up. There's the CPAP machine, and I've heard of a BiPAP machine. What's the difference, and what are the conditions where a BiPAP would be more appropriate?
Sure. So CPAP stands for continuous positive airway pressure, which means that a pressure is set. Say if a person needs 10 centimeters, 8 centimeters, a person will get the same pressure of air throughout the night. So it's a continuous positive airway pressure. Whereas BiPAP machine or a bi-level device, as the name implies, there are two levels, bi-levels. One is when a person is breathing in, which the pressure is going to be high, and the other pressure when the lower pressure, which is when the person is breathing out. Now, there are different types of BiPAPs as well. Most of the time, bilevel or BiPAP devices are used for patients who have difficulty breathing in terms of the work of breathing, not necessarily that there is an airway obstruction, because CPAP can clear up that obstruction. However, patients, for example, who have neuromuscular disorders, whose muscles are weak, they cannot breathe, or people who are so they've become morbidly obese where when they sleep, they can't do the work of breathing, the BiPAP can help with that. So in general, we go with the CPAP unless somebody needs BiPAP for ventilation where they can't do the work of breathing for the reasons I mentioned.
Excellent. Thank you for that. So let me see, a more general question. So how do doctors conduct the annual Medicare wellness exam so that it is meaningful encounter with a patient who has no health issues and only sees their PCP once a year? And there's multiple parts to it, so let me just stop there, and maybe one of you, maybe Dr. Yakuri, can answer if you had any of that experience with an annual Medicare wellness exam.
So as in the nature of my practice, it's not something we really see. Clearly we are referred patients, on when they have their annual wellness exams, if there are preventative health things that arise, such as preventative colonoscopy, screening colonoscopies example, we will see those patients when they're referred by their primary care doctor. A lot of that, if I'm understanding the question correctly, some of the things that that are addressed during those wellness exams are, basically preventative health interventions. So things like your colonoscopy, prostate, mammogram, as an example, annual gynecologic exams as indicated in that age range, vaccination status, also things like checking blood pressure, cholesterol levels, blood sugar levels. These are all appropriate preventative medicine maintenance functions, if you will.
Okay. So let me ask you something related to endoscopies, right? I mean, it's the tube that goes in the mouth, but when is it used? Why would we do that? Why would we take a tube inside the mouth, and what are we looking for? What's the purpose?
Sure, that's a great question. So an upper endoscopy, or EGD, which stands for something much longer, is a flexible fiber optic camera with a light at the end that allows us to examine and also treat a variety of diseases and disorders. So diagnose and potentially treat a variety of diseases and disorders of the upper digestive tract, which includes the esophagus, the stomach, and the first part of your small intestine called the duodenum or duodenum. So there are a variety of reasons why we might recommend an endoscopy for an individual. These include, but are not limited to, evaluation of reflux symptoms, evaluation for trouble swallowing, evaluation of chest pain in some instances, evaluation of upper abdominal pain, the treatment of bleeding that we believe is due to an upper digestive source, say from a stomach ulcer or an ulcer in the small intestine or esophagus. So it is a procedure that is used to both assist in the diagnosis of upper digestive issues or problems and evaluation of those issues, as well as potentially for the treatment of a variety of those conditions as well.
So while we're talking about, upper digestive system, there was a lot of, news coverage about this commonly used antacid medication called Zantac. And there was talk about, pulling that off the shelves because there might be cancer concerns. What can you tell us about that? Is it still available? Is it safe to use? Are there other alternatives that people should be using? Because a lot of people use it.
Yeah, that's a great question. So the class of medication that Zantac, or the generic name ranitidine, falls into is a class of medications called H2 blockers or histamine blockers. This is one way in which we can lower acid production in the stomach and therefore reduce acid-related symptoms. Ranitidine and its other counterparts are very effective for many patients in the long-term control of acid-related symptoms. A lot of times what we find is this medication is very good in terms of what we call on-demand. So you have a pizza or a glass of wine, and your upper digestive, heartburn, reflux symptoms really flare up, and you need some relief immediately. This class of medications, the H2 blockers, are very effective for kind of this on-demand symptom issue. Longer term control, or patients who require long-term control of acid symptoms, will generally transition to the generic forms of, say, Prilosec, Nexium, things like that, which is a different class of medication called a PPI, or proton pump inhibitor. Those medications also reduce acid production, but it's a different mechanism by which they do that. So the question regarding the carcinogenic issue, potential cancer-causing agent in ranitidine, is a good one that I'm not as familiar with, but it does apply to both the generic and the name brand Zantac. So those have been completely pulled from the market. But Pepcid, or famotidine is the trade name, is another option for patients who are looking for a drug in this class that functions relatively in a very similar way, as well as another medication called cimetidine, which tends to be used a little bit more in the pediatric population, but is also very effective in adults.
So one of the common frustrations for all of us is, right, I mean, you get medication because you're trying to treat a problem, and then there's a list of side effects and lots of coverage, don't do this, and this one's now not good. So you mentioned Prilosec, for example. There was coverage a little bit ago that, especially for seniors or people who are taking it long term, might have issues with bone fractures, and seniors are at a higher risk anyways because osteoporosis sets in with age. What can you tell us about that? What is the realistic risk of long-term use with these medications, and what should one person do? I mean, should they take them, not take them?
Yeah, that's a great question, and one that we literally just have that discussion every day in the office in my profession. And so this class of medications, proton pump inhibitors, of which there are 6 of them available in the United States, either over the counter or by prescription, depending on the dose and type. A few years ago, there was a flurry of research suggesting that long-term use, high-dose long-term use of proton pump inhibitors could be associated with some problems not from a digestive standpoint, but other medical issues, such as low bone mineralization, so perhaps aggravating osteopenia and osteoporosis, low magnesium levels in the blood, potentially an increased risk of digestive tract infections, maybe a risk of low iron levels in the blood. And then there were some studies out of Johns Hopkins looking at perhaps issues with dementia, and then out of Germany looking at perhaps these medications potentially affecting kidney function. The lay press got a hold of these studies and kind of had a field day with them because it's good news, and a lot of people are on these medications, so you sell a lot of ads and get a lot of people to watch whatever you want them to watch. And so there was a lot of running with that, and we literally at that time had patients calling the office every day saying, do I need to be on this? I need to come off of this. That aside, one problem with that is we saw en masse primary care physicians kind of just stopping these medications in people. A second wave of studies came out within the last 3 to 4 years, suggesting that the first wave of studies was kind of overblown. This unfortunately happens in medicine not infrequently, as the other medical professionals on the Zoom here can attest to. Is another wave of studies comes out that says, maybe we were a little quick to judge and quick to rush to blame these medications for so many problems. What I tell my patients in my own practice is the following. One of my goals is if I can get you off a medication, I would love to do that. And as an internal medicine subspecialist, as a gastroenterologist, part of what I do is trying to reduce the number of medications people are on, because you'll see, especially in our folks who we're speaking to today, a lot of medications that perhaps if someone sat down and was very thoughtful about what people are on, they could perhaps come off of some of those. So we definitely try to do that no matter what. That's good medicine. Look, you need to consider acid reflux disease and potential consequences of uncontrolled acid reflux disease, the development of potentially precancerous changes in the upper digestive tract, the development of narrowing or strictures of the esophagus that can lead to trouble swallowing, choking, and aspirating. The development of peptic ulcer-related issues. These are some potential consequences of discontinuation of these use of medications. So I encourage my patients to say, look, you need to look at acid-related disease in the same way that you would look at high blood pressure, diabetes, cholesterol, thyroid issues. These are problems that, if left untreated, lead to downstream other potentially more serious problems. And the medications used to treat those conditions also have side effects that you need to consider. But you weigh the risks and the benefits of the medication and decide whether or not the patient, and you and your patient decide whether or not it's an appropriate medication for them to be on. That's the conversation I have with my patients. I, in my own practice, I'm very comfortable with patients being on long-term proton pump inhibitor therapy if their medical condition necessitates it. As someone who does some more advanced type procedures in my specialty, I offer some minimally invasive therapies to treat acid reflux that could potentially get patients off medication long-term for the duration. And there are a variety of surgical techniques that are more invasive that can also that are also available in the appropriate patient to also potentially control the reflux and get them off medication. So in 2020, we have a lot of options for the management of these patients beyond medication.
Well, thank you. And we get this question too, because when we give out vaccines and people are worried about side effects and all those things, and my sort of off the cuff remark has been, everything we do has a side effect. Either the food you eat can cause you problems, water you drink can cause you problems. So is any medication. You got to kind of weigh the risk benefit and keep moving. So I know we're getting close to trying to wrap up. So we've got a few more minutes left. I just want to make sure we cover a few questions that are here. They're very general, so any of you can answer. One of the questions was, what advice can we give to our seniors about drinking water from a source other than a water spigot in your house? What do you do? I guess the concern is related to water safety. Is there anything in our area where you would advise don't drink out of a tap and drink out of something else, or is our area generally okay? I know people have moved here from other places where water supply has issues. What is your experience telling you in your practices? Do you see any issues related to that?
In Dallas-Fort Worth, I have no issue with our patients and citizens drinking tap water.
Absolutely. Our experience has been the same. In fact, I moved from Michigan, and I saw these signs that we have top-of-the-line water systems, and they have signage across certain cities. So I wondered about that, and I asked a few folks, what is this about? And they explained it real well. The water supply here in the DFW area is top-notch. The cities do a great job. They're very proud of their water systems. Not to say that problems don't occur. Now, if you heard the news, right by Houston area, they've had an issue with 8 or 9 cities having a brain-eating amoeba in the water. So there's been advisories issued. So time to time issues do occur, but overall, I think the water system in Texas in general is pretty good compared to other states. Okay, other questions. This is again very general, and if either of you all feel comfortable, somebody has an infarcted spleen, and do they need to worry about complications that could occur from it? What are the precautions one should take?
Yeah, this is something we're often asked as digestive specialists, though the spleen is not part of the digestive system because it's in the abdomen or the abdominal cavity and related to digestive issues. I think the short answer is it depends on the reason for the splenic infarct. Most splenic infarcts are benign and don't have particular consequences, clinically speaking. It depends on the amount and the territory of the spleen that's involved. But more importantly, what led to the splenic infarct is probably of as much, if not greater, concern that needs to be evaluated.
Okay. Another question related to peripheral neuropathy. So maybe Amanda, you can get back on that. And so can having a peripheral neuropathy cause symptoms similar to or the same as a TIA, a transient ischemic attack? For example, a whole arm becomes numb and all the feeling is momentarily lost. The mouth can be affected as well.
similar in quality, different in duration. I would say I would anticipate. Your TIA is something that comes out of the blue in a perfectly otherwise healthy person, and lasts for less than 24 hours. Otherwise, your neuropathies that are because of impinged nerves or because of peripheral neuropathy due to diabetes are going to be more chronic, and you're going to have underlying pain issues already existing beforehand. So I would say if there's a good rule of thumb, if there's pain to an area and then you get the shooting nummy kind of sensation, less likely to be a TIA. Always a good idea though, if you have a concern, to call your primary care physician.
Another general question, do you feel that lymphatic drainage massage is beneficial for persons with lymphedema? And also, what type of specialist would be the best person to refer a person with such a condition to? Who would deal with lymphedema?
I'm aware of some lymphedema clinics. In particular, I previously worked in an office that had a lot of head and neck surgeries. And for lymphedema there, they would refer to a lymphedema clinic. Now, in particular, where those are, I'm not sure, but they exist, and I bet they could be Googled.
And any thoughts on is there lymphatic drainage massage that can be beneficial to folks with that?
Right, that's the primary modality that I was aware of.
Okay, and maybe let me ask a couple of the docs here. What are some general conditions that people need to be aware of that can cause lymphedema, right? I mean, there's a variety of things that can do that, but what do you see commonly in our area?
You can, oftentimes this may develop if there's been a surgical intervention that may affect the surgical or other procedural intervention that could affect the lymph drainage in a particular extremity, arm, the lower extremity. Say, as for example, in patients who've undergone breast surgery for breast cancer and then reconstruction, the lymph drainage system going down the same side of the body as the breast, the arm can be affected, and there can be impaired lymph drainage. Certain chronic conditions, congestive heart failure, underlying pulmonary diseases, I can also have some effect on that. But a lot of times it really has to do with an injury, an insult, or some post-operative situation related to where that particular lymph system drainage is.
Absolutely. So one last question. What is a common cause for leg cramps? The person has excruciating cramps, drinks plenty of water. Is there anything that can be done from a nutritional supplementation standpoint or physical exercise? Or do they really have to go get it checked out at a doctor to see what might be causing it?
I think any form of leg cramping that has not been previously evaluated, you certainly do need to seek evaluation for that, especially if that cramping and pain occurs when you're walking. It could be concerned that there's an impaired blood supply to your legs, and that certainly needs to be checked. Certainly, electrolyte disturbances, potassium, magnesium levels can also affect that, and certainly there may be some underlying neuromuscular issues as well.
You know, I mean, we do see a lot of leg cramps, and you're absolutely right. It has to be evaluated, but sometimes people can confuse restless legs with leg cramps. But leg cramps are pretty clear cut, you know, where your leg is getting into a cramp, where you're having a pain symptoms. But restless legs is different than leg cramps, or there is some comorbidity. I mean, there is no clear-cut treatment. Obviously, factors should be ruled out like blood supply, but some studies suggest using magnesium can help. Also, sometimes exercising, squatting, if there's no other organic reasons for the leg cramps, I think squatting is one of the exercise, or exercising is helpful with that.
Absolutely. Well, thank you all. I know we're at about 45 minutes in, and you all have busy days, so we appreciate you spending your time with us. And again, trying to make this event a success despite the challenges related to the pandemic. Hopefully next year we'll probably be doing this in person, and I get to visit with you all in person. So thank you again for joining us, and we'll see you sometime down the road.
Thank you so much.
Thanks.